Good afternoon, friends. We are here now with this new session, which is going to be on the breaking the Chakravyuh of complex, challenging cataracts with innovative surgical techniques. We have the speakers with us here, Dr. Harshul Tak, a very renowned cataract surgeon from Jaipur, Dr. Virendra Dr. Vinod Arora. He's a well-known cataract surgeon again from Dehradun, and Dr. Malay Chaturvedi on my left side. He's from Kanpur and very, very well-known cataract surgeon. I'm Dr. Rajendra Prasad, and I'm from Delhi. So to start with, we have a keynote address by Dr. Gerd A. U. Effort. So he's going to speak on toric ion calculation in complicated situations.
Okay, thank you very much. Good afternoon. Can I have my slides? There's nothing on the monitor. Yeah, the monitor's black. Oh, this one. Yeah, here we go. Okay. Yeah, I'm going to talk about toric IOL power calculation challenging cases and what kind of possibilities we have to overcome complicated cases or even cases after keratoplasty and things like this. Let's see if it works. How can I forward? Okay. Yes. I work with a lot of companies and do contract research for them, so I'm exposed to more or less all the available IOL technology. And in Germany and Europe, we have a very long tradition of toric intraocular lenses. For more than 20 years, we have toric lenses from local brands like Zeiss or Dr. Schmidt or other companies, Oculentis, and we also have customized IOLs, which are really made by order for an individual patient. So we have a very long exposure of this, which includes also multifocal toric as well as so-called toric add-on lenses that you put on a pseudophakic eye in addition to the already in the capsular bag implanted lens. So we have a quite long experience, as I said, also multifocal toric. I personally have implanted the worldwide first radar M-Flex toric in 2005, so it derives from a long time. When we talk about toric IOL implantation, we always have to look at our parameters, and you all know that we have the corneal refractive power, and this is usually in dioptric power, but it's never really measured. Yeah, you always measure only radii in millimeters, and then it's recalculated. There's no device measuring actual dioptric power of the cornea. We have to remember that because there are several so-called formulas that calculate from the corneal radii to the refractive power. And there's one thing in the formulas, like the refractive index, which is different in different machines. Yeah, if you have a Pentacam or Zeiss IOL Master or other devices, this N can vary between 1.331 to 1.338. So you may think it's not much of a deal, it's the third number after the comma, but the same refractive power here calculated with this, and with this it comes up 46.0 and here 46.9, so it's almost 1 diopter difference just by the calculation. And once you know that, you just need to check on your machine. And if you want to compare, for example, different machines, and you're wondering why there's always a difference, it may be just a simple reason like this. Yeah. Important also for the IOL toric calculation, which is nothing you have to do yourself. I mean, this is implemented in most of the companies' web pages and so on. It's the vertex distance, because the spherical power and toric power at different planes are different. As it's called the vertex distance effect. And the vertex is the distance between the back surface of the corrective lens, so in this case our intraocular lens, and the front of the cornea. So this can have an impact in some formulas which may end up in different toric power IOL calculations. It is not such a big problem in routine, but this combined with, for example, the posterior corneal astigmatism can give us a little bit of pain in the low astigmatic corrections. If we are talking about 1 or 1.5 diopter, and afterwards we're wondering why the patient still has 0.75, this derives from all these little factors together. In general, if you have a toric misalignment, there's a correlation. 3 degrees of misalignment translates into 10% reduction of effect. So if you have 30%, you have 100% reduction of effect or no effect anymore. And at 90 degrees misalignment, of course, you have the doubling of the initial cylinder. But 15% misalignment already has a 50% reduction of the effect, which is, it's easy to remember. If you just remember the 3 and the 10, then you can relate to that. What is the practical consequence of this? This is a nice paper here from my group, from Dr. Jin from China. A misalignment of the axis results in a hyperopic spherical change. So the patient becomes more hyperopic, of course, in the reduction of the astigmatic correction and in the change of the astigmatic axis. There are programs where you can really look at, if you re-rotate the lens, what is the impact of that in the final refraction. But most of the time it comes out more hyperopic if you're off axis. There are different ways to calculate that. Normally you shouldn't do it yourself. You just use the online calculator, or even a company is doing it for it. So the big companies like Alcon or J&J, they have all this. And always be careful that the induced astigmatism, the SIA, is included. And if you use toric IOLs frequently, really check also your induced astigmatism. Just don't put just in 0.5 because somebody told you. You may only have 0.25 as an induced astigmatism, depending on your incision, or you may have even more. So you should really check a little bit on it. If you look at 20, 30 lenses you have implanted, just normal monofocal lenses with your current incision, you get an idea about that, and then implement that individually when you do that. In the Asia-Pacific region, the Barrett toric calculator is quite popular. It's accessible through the APA-CRS webpage here or to the ACRS webpage here. And it also looks at the posterior corneal surface, which may not be really a big issue in the routine application, but in some specific difficult cases, especially as I just told you about the lower grade of astigmatism, half a diopter more or less can have an impact. If you have 10 diopters of astigmatism, half a diopter has no impact actually. So what about complicated cases? Very high astigmatism you can have in cases of patients that have already undergone perforating keratoplasty. So these can be extremely well. And in these cases in Germany, we don't really put a toric lens directly in the capsular bag. If we do a cataract surgery in a PKP eye with a high astigmatism, what we put in is a normal monofocal basic lens in the capsular bag, let it rest for 6 or 3 months, and then we do the correction of the corneal astigmatism with an add-on lens. The reason is you can much easier and more precise correct it. And the other reason is if this patient receives another keratoplasty, maybe even 10 years later, you can just remove the add-on lens and then correct it accordingly afterwards. So you're not depending on a lens that already sits inside the capsular bag. There are different variations that you can have. In Germany, we have Dr. Schmidt, Rayner, or First Q. These are 3 companies where you can get the add-on lenses. And they can make individually at very high toricity. We recently published a paper where we put together 21 eyes with very high astigmatism and the corrective outcome. Most of them were after penetrating keratoplastic, but there were also some with remaining high astigmatism after cataract surgery or congenital astigmatism. And the average add power we had were like 8 diopters, minus 15 to 6 diopters. And you can see already here, if you just look at the distribution, that you can almost, in these complicated, even irregular astigmatic cases with an add-on end, you can cut down almost 70 to 80% of the astigmatism looking at the vector analysis, and the visual acuity goes up and stays stable. We have a 24 to 36 months follow-up in this study, as you can see here. Let's look at a very challenging case here, and I will show you several cases. Here it was like 8 years ago, a patient received a triple procedure for bullous keratopathy. At that time, of course, also IOL calculation is not so easy if you do simultaneously the keratoplasty plus the intraocular lens. A year later, he got the suture removal. 2 years later, he presented with this refraction. He had 21 diopters of astigmatism, which is something people can have. It's very high, of course, extreme, but you can see that. You see here the topography, very impressive 2 years after this PKP. So we calculated individually an add-on lens of this. That is a hydrophilic lens with a 4-point fixation, which really is very good in terms of rotational stability, much better than some of the others. So the calculation with the company together in this specific case ended up with a lens with -18 and +25 cylinder. And this was a targeted refraction we got with a spherical equivalent of almost 0, but it was like +1, -2.5. And when we did the surgery, we actually ended up even better. We almost corrected the whole astigmatism, and the patient had uncorrected visual acuity first month of 0.2 logMAR, which is 0.63. And then after 8 months, after everything has healed out, he was at almost 20/25 or almost 1.0 uncorrected, and with a slight correction, it was good. So you can really correct these high amounts, and the patient are tolerating this type of toricity in an intraocular lens without having any problems. Another challenging cases are astigmatism after refractive corneal surgery, and even in combination with some presbyopia treatment. So this is a patient here which was quite young and had a LASIK procedure a couple of years ago in 2000 with a hyperopia. And hyperopic patient always come out on the long run very bad, we have to say that. She got like a 7.5 diopter of LASIK. They didn't correct everything, just 5 diopters. But the post-op refraction, when this lady came to us, was plus 4.5 in the one eye and 5.75 with almost 2 diopters of cylinder. With that, she had a decent visual acuity, but it was quite high. So these are the topography images with the pentacam, as you can see here. It's not really very regular, but it's okay. We calculated here, and then we use for the spherical equivalent the highest L hyperopia.
Sorry, you have to sum up, please. You have to sum up, sir.
I need to sum, okay. So there are a couple of possibilities that you have, especially if you go into the LASIK patients, and, oops, the wrong way. And we have the means to do that also here in a customized toric multifocal lens patient who received a customized lens. And the most complicated case we have was one who had already a toric lens in the bag, and we had to calculate another add-on lenses, and it also ended up very well. So the conclusions are that toric intraocular lenses is possible in challenging cases, high astigmatism. Think about add-on lenses available here, and accurate barometry, preoperative access marking, and this is of course very important. Thank you very much.
Thank you very much for the nice presentation. So now I'll request Dr. Harshul Tuck to speak on posterior polar cataract, new technique in the prevention of the posterior capsule disruption.
Good afternoon, everybody. At the outset, I'd like to thank Dr. Rajendra Prasad for including me in his course. It's a wonderful course we've been doing for so many years now. And we all know Dr. Rajendra Prasad is a great innovator. He's a terminator, I'll say. So I'll be speaking about the posterior. Can I have the feed from my laptop? Yes. So I'll be speaking on the management of posterior polar cataract. We all know that posterior polar cataract, they are very dangerous. They pose a significant problem to all the phacosurgeons because the posterior capsule is either ruptured at the posterior pole or it's very weak, it's tightly adhered to the cortical layers. So there are high chances that there will be a posterior capsule defect. So the feed is not coming here, yes. Okay. So we are talking about these kind of true posterior polar cataracts which have onion ring type of appearance, and we know that in these kind of these are true posterior polar cataract, and there is high chances that when we take out the last this disc, there's going to be a posterior capsule defect. So this technique I presented in ESCRS, I guess 2013, in Bob Osher's symposium. There's a dual site phacoemulsification. So this is the left eye of the patient, and it's very important that we make a capsular axis of 5 or 5.25 millimeters. The capsular axis should be of adequate size. If it's too small, when we are doing hydrodelineation or any other procedure, it may increase the capsular pressure. Or if the axis is too large, there are chances that there is a PCR. We are not able to put the IOL in the capsular bag. So in that case, we need to put the 3-piece IOL in the sulcus, and we need to do optic capture. So the axis sizing is very important part. So here, this case had grade 3 nucleus with posterior polar cataract, and these cases, after a few strokes here and there with the phaco probe, there occurs hydrodissection itself, or the nucleus start rotating. So there is no need to do any hydrodissection or delineation. So here you will see, this is 1.8 millimeter co-MICS tip, which I routinely use. And I go there, trench in the center, and hold this, and give a small chop here. I'm not doing much of the lateral separation, taking out a single piece of the cake. Now the idea here, whole idea here was not to do any rotation of the nucleus at any stage or of the cortical matter, so that we can delay the opening of the posterior capsule as much as possible. And now see, I rotate the bevel to the right side and again give a chop here and take out this nucleus piece here. So once, now I can't take out much of the nucleus from this side and here from the same incision. So what I decided to go superiorly, make another incision here so that I can attack the opposite side. So it's very important that you maintain the anterior chamber, you maintain a closed chamber. So put OVD before taking out your phaco probe. So I'm injecting the OVD, turning the irrigation off, and this is the, I've shifted to superior side and making a 1.8 millimeter incision. So now I can attack the opposite side of the nucleus without rotating it. If the posterior polar cataract is very soft, and so there is no need to make 2 pores, then you can go with bimanual irrigation aspiration cannula itself, doing hydrodelineation. But if you have a grade 3 nucleus, grade 4 nucleus, it's always better to attack them from the opposite side without rotating them. So now see the whole nucleus, this is the last nuclear piece which I am taking out. So once you have taken out these nucleus, now we are left with the epinuclear shell here. Now I am separating this epinuclear shell from the capsular fornices, but not taking out the disc. So once I loosen it up from this opposite side, I again inject OVD, come back to the same site, temporal site, and loosen it from other sides also. See, the disc is still there. So it's important that you take out you loosen out the whole epinuclear shell and then take out the disc in the last. So when you do everything in a controlled manner, even if there is a PCR and you have a closed anterior chamber, you are not disrupting the anterior vitreous phase. Now see here, once this sheet is taken, I can see that there is a posterior capsule tear is there. So don't come out hurriedly, maintain the anterior chamber. As you can see here, there is a big PCR here. So I put one more irrigation cannula from the BSS bottle before taking out the phaco probe, and go ahead and do, because there is no anterior vitreous here, so I can easily aspirate the cortical matter, exchange hands, maintain the anterior chamber. I can see a big defect there. So take out this whole cortical matter, and you can see the posterior capsule is dancing here, but there is no vitreous. Now I could see the edges of the posterior capsule tear there. So I go ahead and put some chondroitin sulfate based OVD and use a microrhexis forceps to convert this irregular tear. So whenever possible, if you can find the edges and they have not gone in far periphery, it's always better to try to convert it into a regular tear, regular margins. So this is a single piece Hoya preloaded IOL. The leading haptic has to go in the capsular bag nicely so that the remaining optic and the trailing haptic, they goes in the capsular bag. I put some Miocol, take out OVD, and this finishes the case. So see, this is the slit lamp video on the first post-operative. You can see that the IOL is nicely sitting in the capsular bag, and this is the posterior capsule tear which I converted into a nice posterior capsulorhexis. So whenever you have a posterior polar cataract, if it's a very soft kind of cataract, you can do hydrodelineation, take out the central disc, and slowly aspirate from all around and try to take out the disc in the last. And if you have a nucleus grade 3, 4 hard cataract with these kind of true posterior polar opacity, it's better to do from the dual side if possible, so that the torsional movements of the nucleus doesn't rupture it in the initial stages itself. Thank you very much.
Thank you very much. Any questions from the audience, please? And meanwhile, I request Dr. Rajendra Prasad to come on the rise.
Yeah.
Thank you, Dr. Harshal. Thank you very
sir.
much. Now, next speaker is Dr. Rajendra Prasad. He is Director and Consultant Ophthalmologist at RPI Institute, Delhi. He has won a lot of awards, and in fact, day before he got Innovator Award at he was here only. So he is popularly known as Terminator because of this technique, and he is going to demonstrate that technique again with us, Dr. Rajendra Prasad.
Good afternoon, friends, and my friends on the dais here. The topic which I'm going to talk about is terminal chop. This is basically a technique for the hard cataract management, and the basic concept of this technique is the breaking or cracking the nucleus and then emulsifying. See, basically, like see, techniques what we all have been using till now is basically what we try to do is we try to pull away the nucleus from the center. I don't know where he started. Give me the first slide. First slide. Okay. So, if you look at these hard cataracts, have always been a challenge. The greatest challenge in these hard cataract is breaking them down into two complete segments and then emulsifying. So this is the greatest problem, because unless you segment the hard nucleus into 2 pieces or 4 pieces, and that should be a free segments, then only you can very simply and very easily emulsify these pieces and draw the pieces on the phaco tip and then emulsify. Then emulsification becomes very simple. But if you are not having the complete separation of the nucleus or complete division of the nucleus, then we tend to struggle. We tend to use a lot of phaco forces, tend to use a lot of manipulation in the anterior chamber within the capsular bag, and which could endanger many of the important structures like capsular bag trauma, endothelial decomposition, and so many things, and you may end up with many of these complications. So I'm going to describe a very, very simple technique which is called as a single stroke terminal chop. It's a very simple, swift, and safe, 100% effective surgical technique to break these hardness of hard cataract. So you can break them. If you are able to break the nucleus into 2 pieces, then you know that everything, the whole procedure becomes very simple. So to break, this is my publication, and the mechanics of terminal chop is basically what we are trying to do is we are trying to initiate a full thickness nuclear crack at the open edge, weakest, soft, and thin equator of the nucleus. So crack has to start from the equator. So that is very, very important, and for that your phaco probe has to go towards the equator, not towards the center and the deep into the center of the nucleus. Now you could see here, we are initiating a crack at the equator. Now this is a crack. This creates a sound actually, because when you're trying to hook this nucleus with this specialized chopper, you get a crack sound, and then the whole nucleus divides into 2, and the crack automatically traverses from the equator from one side to the equator on the other side, and you get a complete 2 segments of the nucleus. This is the mechanics. Like we initiate a crack at the equator, and which automatically traverses towards the equator on the other side. Then the whole procedure becomes simple, because if you have a crack of the nucleus, then it's just splitting the nucleus into 2 pieces. So this can be repeated on the rest of the segments of the nucleus, like heminuclei, because once you divide into 2, then you can divide the nucleus into 4 or 6 pieces, depending on the hardness of the nucleus. But on the other hand, like other techniques where what we have been doing, we don't have the crack, we try to split. So that is the reason, like we have to put a lot of stress and a lot of manipulation, and still most of the time, or many times, we do not get the complete segmentation of the nucleus, and then we start struggling. So this is the device which has to be used for cracking, because this is a terminator, which is basically not a chopper, it's a cracker. When you actually put this, hook this chopper at the equator of the nucleus, and slightly when you draw the chopper into the nucleus starts cracking. The cracking happens because of the stress phenomena, the stress concentration, what you can see here. And this is how the chopper is used. The choppers, otherwise, it looks like any other chopper, but the difference is there in the tip of the chopper. The tip is wedge-shaped, wide, angulated, and its posterior surface is wider. So when it hooks the nucleus, when it goes into the nucleus, it creates a stress concentration. Now this stress concentration breaks the nucleus. So you don't have to actually pull the chopper from the equator towards the center. It's just hooking, and just simple little movement of the chopper into the nucleus breaks the nucleus into 2 pieces. And you get a complete cracking and complete segmentation of the nucleus. The principle of this technique is basically based on the Griffith's theory of brittle fracture. Griffith has done a lot of work on rock excavation system, and according to him, these hard objects are basically resistant to the compressive forces, but they are very, very susceptible to the tensile forces. Tensile forces means the fracture forces. You can, these hard objects, you can fracture them, but if you try to crush or try to cut them, then it's very difficult. So similarly, these hard nuclei also, you can very simply break and crack them into 2 pieces. So to achieve the mechanics, or to break the nucleus at the equator, you have to follow the following points. So first and most important thing is you have to create a 5.5 to 6 millimeter of central axis. You can see both the videos. On the right side, it's the animation. On the left side is a real-time video. And what you need to do is you need to create a rexis of 5.5 to 6 millimeter. Your rexis should not be too small. In any case, when you're dealing with the hard cataract, you keep a larger rexis for the better manipulation and better holding of the nucleus. Once you create this, and then you make a small central trench. So like I'm making here on the right side, you can see very simply, a very little small trench. This is not exactly the trench, and it's a small groove. So just to fit in the phaco probe at a proper plane. And then impale the phaco probe towards the equator. It should be superficial. You don't have to go deep towards the posterior capsule as we do in the vertical chop and the horizontal chop. Here you have to go superficially towards the equator. And once you hold the nucleus, then you slightly draw the nucleus. You can see you have to slightly draw it. And then you see the edge of the nucleus. Once you see the edge of the nucleus, hook it with the chopper. Once you hook it, then the chopper has to be drawn a little bit. That is hardly 1.5 millimeters. Drawing of the chopper starts the nuclear crack. So that crack actually happens when you're drawing the chopper at the equator. The crack happens, and this crack actually goes through and through to the center and towards the equator on the side. The best part of this cracking is like you get a full thickness cracking. You are never left with the posterior plate, which happens when you are splitting the nucleus at the center with the horizontal chop. In horizontal chop, you are trying to bring the chopper from the periphery towards the center of the nucleus, trying to cut it, and that does not happen in a hard cataract. It becomes very difficult. So you have to crack the hard cataract. So this is the basic and the most important part. You crack the hard cataract, and once you crack the hard nucleus, then you can very simply draw them and emulsify very simply. So you can see these two videos simultaneously here. So I'm showing both them together. Time is left. Okay. And now you can see here in both the videos, because very hard nuclei, and how simply you can crack them. You can see on right and left side of the video. You have to just impale the nucleus superficially. So that is the most important step, superficially towards the equator. Hold the nucleus, draw the nucleus, you can see the edge of the nucleus. Hook it. Once you hook it, you crack the nucleus. So cracking happens at the equator itself, and then you get a complete fracture of the nucleus. So the most important step in this technique is the position of the phaco probe. You can see the phaco probe has to be superficial, and it has to hold the nucleus at the equator. You have to draw it and then hook it, and then draw the chopper within the nucleus, in the periphery of the nucleus, and while drawing, you get a crack. You can see on the right side the crack what you get. Because I have not drawn the chopper from the periphery towards the center, but the crack has traversed from the periphery towards the center and the equator on the other side. And you get a complete fractured nucleus. The technique is very safe, very simple, and it's least traumatic, because since you're not handling the nucleus too much or not doing too much of manipulation, you don't get any endothelial cell loss or adjacent tissue injury, and it's very effective. 100% of the cases you can break the nucleus into 2 complete pieces. It's very swift. It takes hardly few seconds to break the nucleus. So I'm not talking about the speed, but yes, definitely, because if you can break the nucleus swiftly and with a speed, is the best part, because otherwise we keep struggling and we keep trenching, doing too much of grooving and so many things we do in these hard cataract, and then you do not get the segmentation of the nucleus. It's very simple, easy to perform, and very easy to learn technique. So the terminal chop is the way to go for the hard cataract. And the people, those who have been acknowledging this technique, and those who are performing this technique, because Dr. Binod is here. Like Dr. Binod is one of the very proficient phacosurgeon in Dehradun, and he's doing this technique very frequently and giving me a very good report about this. Thank you very much. So I'll just put one important word in the end is like, see, actually, because if you have a hard object, especially the hard nucleus, if you are able to crack it in the beginning, if you are able to crack it and then break into 2 pieces, before you start trenching or doing anything into it or grooving, and before you start emulsification, the process becomes very simple. So basically, you have to crack into 2 pieces, and crack happens simply with the stress force. And the stress force is created by this specially designed chopper and the technique. And it has to start from the equator, and which is the weakest point of the nucleus, and the crack has to be complete. And if you get a complete cracking, then you can emulsify very simply. Thank you.
Thank you, Dr. Rajendra Prasad, for showing so nicely your technique. And in the sequence of breaking the complicated situations in cataract surgery, I call upon Dr. Amit Purwal. His topic is Morgagnian intumescent white cataract fixing the Argentinian flag sign, a new technique. He happens to represent central zone of member ARC. Dr. Purwal is a very experienced cataract surgeon. Dr. Purwal.
Thank you, sir. So, no financial disclosures. Before I start, let me brief you all with what is Argentinian flag sign. Basically, this was a term coined by Daniel Perron. In this, there is a peripheral split or the radial tear of the anterior lens capsule after the first puncture while doing capsulorhexis in white mature intumescent cataracts, which is seen when the capsule is stained with tryptine blue. So, it resembles the Argentinian flag, hence it is called as the Argentinian flag sign. So, this is a short video. You can see in this video that I punctured the anterior capsule after staining the anterior capsule, and I am trying to do the rhexis, but then the intraventricular pressure was very high. So, I thought at this particular moment, I'll try to aspirate some of the loose liquefied cortex and see what happens. Suddenly, the capsule gives way on either side. So, it is sort of an Argentinian flag sign, not classical that is the first puncture and there is a fluid. So, when you have this type of Argentinian flag sign, how do we fix it? That is very important. You should never panic, but relax, cool down your temper, and think what you want to do ahead. So, fixing the Argentinian flag sign is very important. So, whenever you have this, you fill the anterior chamber with high density viscoelastic substance. Then your aim should be now to convert the sharp horizontal edges into the semicircular ones. You should always make sure that when you fill the anterior chamber with visco, you should not over distend it. You don't want a concave anterior capsule. You want a flat horizontal anterior capsule. So with the help of a microaxis forceps, micro-1 you give a small nick, a tangential cut, and then convert this horizontal sharp edge into a circular one with the help of a microaxis forceps. You can use a microaxis forceps or a normal rhexis forceps, but in these cases when you are using a 20 gauge side port, the microaxis forceps is of major advantage. So you could see that after making the inferior edge the nice circular one, I thought that the superior edge of the anterior capsule flap is too big, so it will be giving a good overlap. So I again try to trim it. So once you are done with that, then do a gentle hydro. Always make sure that when you are doing the hydro, you should not do the hydro near the cut end, near the tone end of the anterior capsule. So once this is how you are going to fix if there is an Argentinian flag sign. What are the other option available is, you can convert this into a can opener capsulotomy, but make sure that whenever you convert this into a can opener capsulotomy, you never go ahead with the phaco. You always convert this surgery into a small incision cataract surgery, that is a manual small incision cataract surgery. Never go ahead with the phaco when you convert this into a can opener capsulotomy. So do SICS in this case, never do phaco. Now, what happens sometimes? A midway extension of the rhexis. You are doing a rhexis, you are started with the rhexis in a mature intumescent cataract. You are getting a nice circular flap, and suddenly in between midway your rhexis is getting extended. So what you do, never panic. Again, as I told you before, use a high density viscoelastic substance. Now you can give a nick or a small tangential cut at the other end of the anterior capsule. Okay, this is very important that you give a tangential cut, and it should not be a perpendicular cut. If you are giving a perpendicular cut, again because of the increased ventricular pressure, it might give way and there might be a BCR. So give a tangential cut and convert this, start the axis on the other side, and you'll have a nice circular axis. So if you are proceeding with the phaco, when you have this Argentinian flag sign, some important tips. You do a slow motion phaco. I always prefer a stop and chop technique. Most of the time these cataracts are usually soft in this intumescent cataract. So you can just use a very low power settings. I do a stop chop, convert it into two hemispheres. You can either chop into multiple fragment, or you can just flip over one of the piece towards the capsular bag and supracapsular bag and do the phacoemulsification. You have to be very careful. Your manual should be very gentle. You should not be vigorous when you are doing your phaco, because if there is a high pressure inside or more of turbulence inside the anterior chamber, there is always chance of this capsular tear getting extended into a PCR, and you might have a drop also. So this is very important to be followed. Now next step is always be careful when you are withdrawing your second instrument. You should always maintain your anterior chamber as if you are handling a case of PCR. There should not be too much of AC surge or any disturbance. And when you are doing a bimanual phaco, make sure that the irrigating port is not towards the tear end of the anterior capsule. Now in this case, after all this, after the phacoemulsion, I'm injecting a 4-piece aqueous lens. This lens is very thin, very malleable. So when you have, you should be very careful with your IOL also. When you have this Argentinian flax sign, you should not be too vigorous in dialing your IOL. Your IOL should be very flexible and malleable. So this was a very thin IOL. You just have to lift it, put it into the capsular bag. You can see there's a nice opposition of the inferior edge and the superior edge of the anterior capsule, and the IOL is into the capsular bag. So what are the techniques to avoid this Argentinian flax sign? You have the single stage rhexis. In this single stage rhexis, what you have to do is, you can see this all these mature cataracts. Whenever you are proceeding with your phaco, you always make it a habit to strain the anterior capsule with the help of a trypan blue. So now when you are proceeding with the single stage rhexis, you aim for a smaller rhexis. Whenever you have a raised intraocular pressure, intradenticular pressure, you feel that the rhexis might give away. You stop there. Inject the high density viscoelastic substance. Any loose liquefied cortex is there. You try to aspirate a bit. Again, go ahead clockwise. Always make sure that your capsular flap is flat. It is not raised. Re-inject whenever needed. And try to practice to learn and to play with your vector forces. And also, you should be able to perform your rhexis with the help of capsulotomy needle, a normal rhexis forceps, a micro rhexis forceps. These are the instruments you should have in your armamentarium, and you should be able to perform the rhexis with your right hand as well as the left hand, because you never know which hand you want to use at what particular time. So these are the few principles. You can do a single stage rhexis, but the best thing is you should know how to play with your vector forces. Once you know how to play with the vector forces, rhexis becomes quite easy. Another option is doing a mini rhexis or a 2-stage rhexis. In the mini rhexis or a 2-stage rhexis, basically what happens is, you do a small rhexis about 3 to 3.5 millimeter, and then most of the time, as I told you, the cataract is usually soft, so you perform the phacoemulsification, inject the IOL, and then you can extend the rhexis by giving a small nick, tangential nick, as was told earlier, and with the help of a high density viscoelastic substance, and now you can enlarge the rhexis. So basically, the smaller the rhexis, the chances of giving away is very less, and by using this maneuver, you can, this is one of the another option available. So you can nicely trim the rhexis and have a good overlap of the anterior capsule over the optic. Another option is doing a small heart-shaped rhexis. Now, why it is a heart-shaped rhexis? Usually what happens is in this intumescent cataracts is, when you are aiming for a smaller rhexis, as you are proceeding with the rhexis, when you reach the terminal point, naturally you know that the rhexis might extend, so you try to rip it off. Once you try to rip it off because of the raised intradenticular pressure, you get a heart-shaped rhexis. So never to worry about this. As I told you, aspirate the cataract, emulsify the cataract, put the IOL, and then again you can trim the anterior capsule to the desired shape and size you want. Another option you have is the onion pattern rhexis, or also called as a snail pattern rhexis. In this, what happens is, once you have started the rhexis, do a small rhexis, and once you are reaching the end beginning point, you go beyond the beginning point and then again peel it off as if you are peeling off the skin of the onion, or it's the snail pattern rhexis. So by doing this, you have more control over your rhexis. This is another option available, but I would prefer to do a 2-stage rhexis at any given time, because the smaller the rhexis, the chances of giving way is very less, and you can play with it. But these are all the different options. I'm trying to show you all the different options which are available, which the decision has to be taken as it's customized for every case. It can't be, you can't do a 2-stage rhexis for each and every mature intumescent cataract. It depends on intraoperatively, you have to decide what you're going to proceed with. So these are the different options available, and I welcome you all next year for the All India Ophthalmic Conference at Indore. You are all welcome. Please do come and attend in large numbers. Thank you.
Thank you, Amit, for the nice presentation and beautiful videos showing the rhexis creation in a Morgaginian cataract. Any question from the house, like you want to ask Dr. Amit? Okay, so we'll go on to the next presentation by Dr. Vinod Arora. Dr. Vinod Arora is going to speak on viscoflip, new technique for complex soft cataract.
Good afternoon. After seeing these hard cataracts and white cataracts, you would think that soft cataract may be just very easy choice to do. But soft may be a decepting thing. Soft may be tough. So soft cataract is a challenge. The reason is being, it's difficult to rotate. It is difficult to hold by phaco tip, difficult to divide, and there are increased chances of PCR in these cases. So don't take it lightly. So how to manage this thing? The technique is very simple. You have to do a good hydrosection from the multiple sides. And visco, as we know, is a very important tool in our ophthalmic practice. We can take help of the we can do a visco dissection in this case. The soft nucleus material is pushed up into the anterior chamber. You can easily aspirate it with a phaco. Then everything will become very, very easy. So here is a video for that one. First, we do a meticulous hydro from the different sides. It should be gentle, but we have to do it from different sides. But this will not make your soft cortex to come up. Now, we have to use so we are doing meticulous hydro from different sides. It should be very thorough. Now comes the time of visco dissection. We use visco to further bring it forward. So these are soft cataracts, especially the grade 2 one. Now by using visco, we are pushing the posterior capsule a little backward. We are giving a space. I'm sorry, it's not edited. I could have fast forwarded it. So now everything is in the anterior chamber. You can easily aspirate it without using any phaco power, since the cataract is very soft and you are very, very secure and you can easily take it out. So this technique is called visco flip, by which we flip the cortical part, the nucleus cortical part in the anterior chamber. And the rest of the surgery is same as we normally do it, cleaning the cortex and putting a lens inside. So coming to the next step, can we manage posterior polar cataract with this technique? It's almost the same technique. Visco dissection in place of hydro dissection. Last piece visco dissected by viscote. This is the technique. A patient who was referred to, who has a history of dropped nucleus in the first eye and came to us for the second eye. And we already have a posterior polar cataract. We were a little scared that he may have the same problem. So we tried to manage the case. A CCC was done. Now we do a gentle visco dissection. Normally visco doesn't cause a pressure on the posterior pole. There is no sudden pressure on the posterior pole, and in fact it separates the nucleus, even the posterior plate from the back also. But it has to be very gentle, it's not to be thorough. Then we do hydrodelineation in this case. Nucleus is now separated and can be easily removed. So the basic advantage in this technique is we are just pushing the posterior capsular back if we are using a viscote for the last piece especially. If you got a plaque-like thing there and you use a viscote, that will take care, even if there is a rupture, viscote is there to seal it. Your nucleus is not going behind. So it makes the surgery very, very safe. Now we are left with a plate, probably the last piece. We try to remove as much possible. And if you are left with the coat, the plaque sticking there, you can just again use visco for cleaning of this thing. So it makes the surgery very, very safe. So this way, visco is a great tool to help us in soft cataract. Thank you. Thank you very much.
Thank you, Dr. Vinod, for the beautiful presentation on soft cataract, and very nicely explained the problems we come across in soft cataract. These soft cataracts, actually, they have a different character in themselves because, as he very rightly said, like it's very difficult to hold them, very difficult to crack them, and very difficult to rotate. So most important thing in soft cataract is like you can't chop them, and the nucleus is so soft, like your phaco probe may suddenly aspirate the lens material and go into the posterior capsule. So this is the biggest challenge while aspirating the soft cataract, because you may hit the posterior capsule suddenly, because we use a high vacuum, suddenly the whole cataract material will come into the phaco probe and then you may hit the posterior capsule. And so that is the best part, the best technique what Dr. Vinod has explained is do either hydroflip or the viscoflip, like you just take out the whole cataractous complex into the anterior chamber or on the anterior capsular surface, and then very slowly you start aspirating. But many times these soft cataract you may come across with a little bit of brittleness. If the soft cataract has little bit of brittleness, that happens like with the senile soft cataract especially. And there then you can use some sort of chopping technique or cracking technique. And then like divide and conquer, so that kind of technique can be used in these soft cataract. Thank you. So now I will invite Dr. Malay Chakravyuh, and he is a very good, one of the very important innovator, and he has done a lot of work on cataract surgery and devised many new techniques and new devices for the cataract surgery. And he's going to speak on small pupil with hard cataract, managing with new pupil expanding devices. Dr. Malay.
Thank you, Dr. Rajendra Prasad. When he gave me a topic on small pupil, I thought that this is a very small topic and it's not worth it. But when I started exploring it, I found that actually small pupil has become a very large subject. And it's a very hot cake, especially after the intervention of Dr. Suvin. World over, there is a whole gamut of pupil expanders which have come up, and they have really made this small window look wide in a variety of manner, and so much of things are there that you may actually find it very interesting to see. There seems to be a common consensus internationally over the steps by which you should try to address the problem of this small pupil. The options are mydriatics, high viscosity OVDs, mechanical dilatation, pupil expanders, iris retractors, or combinations. The pupil expanders is a full chapter now, and so much of variety is available. We are going to see them one by one. Naturally, it's very difficult to enumerate all of them, but I have tried to cover some of them. So the international brand is Omidria, which is phenylephrine plus ketorolac. Indian version is also available. It has shown that, let me read it like this, 22% of subjects on phenylephrine had a pupil diameter smaller than 6 millimeter. If we compare it with 6% who use Omidria. It doesn't aid in dilatation, but actually it prevents meiosis. So this is a nice pupil expander devised by Professor Asia. He is from Israel.
Go under the iris
And even if you cannot listen the audio, you just see the video is self-explanatory.
Cool little forceps.
And you use a forceps to clip it.
Because it makes the pupil
And
quite
this
large, and it's kind of square, so that when you go to do your procedure,
So basically
like
what
squeeze them
we
together,
notice here, this
pull
is
them out
a
of the small incision.
quadrantic
And
pupillary
it doesn't
expander.
look like the eyes have.
Introduce the inserter through the primary incision, positioning the tip of the cannula centrally over the lens.
This is another
Inject the eye
pupillary
ring above
expander.
the iris by gradually moving the slider forward, while simultaneously withdrawing the cannula to allow the ring to be placed centrally. Completely retract the prongs prior to withdrawing from the primary incision. Next, engage the 4 channels of the ring using a Sinskey hook. Secure the distal channel to the iris first, then the proximal channel, followed by the 2 lateral channels. The positioning channels using a Sinskey hook. Always begin with the distal channel, followed by the proximal channel, and finally, the 2 lateral channels. Align the proximal hinge with the primary incision and position this hinge away from the pupillary margin. Reintroduce the inserter and gradually extend the prongs forward. Carefully position the cannula platform under the hinge and retract the prongs to draw the ring into the cannula.
So I think this is polyurethane made eye ring, which seems to be having a very predictable format of insertion and excursion. And I thought out of all this was very impressive. But in our case, like in international scenario, the problem of pupillary constriction is that they are atonic pupils. In our case, it is different. The smaller pupil, the pupil is small because of the membranous adhesions. And here the things are different. So I'm sharing you this video where I am trying to use a lot of combination. So I tried synechialysis and then mechanical dilatation. Then viscoexpression. And then I shifted to iris hooks. So if we foreplan our forces movement, then putting up this iris hook becomes very simple and safe. And if the stretch is just adequate, iris doesn't come in your way. So basically we are making 6 ports, 4 ports for iris hook and 2 ports for phaco. So if we plan our incision carefully, then the things become very easy and very predictable. So this is the 4th port, and then the capsulotomy is different in such patients, and usually there is a membrane. The cataract behaves very differently, so we need atypical maneuvers to do. The cortex removal is different. Everything is different in these type of cases. And IOL insertion, iris was coming, so we used the second hand. And then, you see, if you remove it nicely and carefully, the removal is also not very difficult. The trick is patient removal. looks quite good. It's not that bad. The point, looking into from where we have started. We did some innovation, and instead of putting a 4 iris hook, I shifted to a tripod CTR. So instead of making 4 ports, you can actually save 1 port. If you plan it as I told you, the things become simpler. So instead of a quadrangle, you can use a tripod. Again, patient removal looks good. This is a downloaded video. It's not good, not very clear, but still it makes what it wants to say about the most popular device, Melugeon ring, which is made of polypropylene. Good for atonic pupillary constriction. But as I told you, that our scenario is different than international scenario. Most of the pupil expanders are coming up now with injectors, and the theme is that you make it predictable insertion and predictable outcome. I still have 1 minute. Yeah. So you have seen this is 4 quadrantic, and you can take it out. This is the slide which I have taken from the Fyodorov Institute, and this is essentially telling you the same steps which I told in the beginning. Phenylephrine, viscodilation, posterior saniculosis, pupil stretching, and pupil expanders. So basically that's what I'm saying, that there seems to be a consensus in approach of expansion, and this may be considered as the prototype of problem facing the problem of pupillary constriction. And there are so many other expanders. This is Gieser ring. I'll just mention them. Morse's pupillary dilator, Clark expander,
pupil expansion ring,
Milvella injector. This is good. I think we must see this before I finish.
The plunger is used to engage the proximal.
It's a really interesting video,
and this will pull the ring back into the shaft.
But what you should see that the video which they are showing is pupil is already dilated, and this much dilatation we will go and operate without dilator only.
Use the proximal
but the concept is
of the ring
phenomenal, and it's good.
The iris,
and this also gives you the idea of how much work is going on in this field of pupil expansion. And before I finish, this is the Sovin's BHACs, very popular. And the video is of Partha, so a neutral surgeon. Although I was not able to put it so nicely as has been demonstrated by Dr. Partha here. This is a 6. All of others were 4 quadrangular devices, and this is a hexagonal device, which can go through a very small incision and it can be taken out through a small incision. So. With this is a brief introduction to the arena of small pupil, and it also gives you a comprehensive picture of what's going on today in the current scenario in the international world. Thank you very much for your patient listening.
Just a small question. If you are using iris hooks, sometimes you see the iris stenting is there. So where do you place your iris hooks? What's the plane you are using? Is the corneal or is the limbal?
I think the trick is that you stretch only that much as required.
Okay.
So your exposure is adequate and your pull is not much. So tenting is less and you get more space. Yeah. Because the phaco instruments which you are operating, they are longer instruments, they are going more into the center, and iris hooks are working in the periphery. So you get enough space actually.
I think this is important that your iris hook should be on the limbal plane. It should not be on the corneal one. Even it can be little subscleral also, doesn't matter. That will keep your iris on the plane. If you try to do it from the corneal, little on the corneal side, it will keep on tending. Second problem you face, well, you try to put your phaco probe. The iris again comes on that side if there is a little tilting with this one. So if you want to handle that one, you can just make a incision, small incision under your this main incision, from where you can put a iris hook and take the iris back. So this iris will not obstruct in the port. That's again a very important trick.
And just one comment I would like to say, that in my hands as of today, iris hooks works better than all other devices.
And nice presentation, Dr. Malay. Just very simple question, like what small pupil size you would go with the phaco and you won't go with the phaco, or you'll use the expanders?
I think it's a difficult question to answer, will vary from person to person and a stage at which you are. But at least we need 5 millimeter pupil to operate safely. So if you are less than 5 millimeter, you must do something to your pupil. If you are happy with expanders, you can try expanders. If you have problem in expander, feel free to use iris hook. Whatever the world says, you don't worry. You do whatever you are comfortable with.
And what are the situation, like what are the clinical situation where you will avoid putting the expanders?
I'm not very sure how should I answer. If you have an answer, you share.
Dr. Vinod, like your life lesson.
Maybe in cases of trauma?
No, actually, I have been using the Oasis iris expanders or the Malugin ring for all my small pupil cases, and I don't find any contraindication for avoiding these expanders. In fact, I would go against the iris hooks because of the 4 or 5 side port stab wounds what you create, plus the 2 stab wounds for a bimanual, and the chances of kinking of the iris tissue at the phaco probe is quite common unless and until you go for a pyramid shape hook insertion. So I don't see any contraindications other than a very, very shallow AC.
Yes, that's right.
Shallow AC, even if you put iris hooks or any pupil expansion devices, the AC depth itself is so small that it is going to be a traumatic surgery. So I would advise in such cases you should do under viscoat.
And I think one clinical situation, like if you have a very ischemic and fibrosed uveal tissue like iris, especially like post angle closure glaucoma attack, or where you already have, because these are the cases where if you put the expanders, the iris tends to tear, and if it tears, you'll have a distorted pupil. And
yeah, I think you are right. With expanders, there is a problem of a space, because ultimately you are doing something extra in that anterior chamber. So as has been mentioned by Dr. Porwal, that shallow anterior chamber is a relative contraindication.
Yeah. And in what percentage of the cases, like you land up with the persistent pupillary dilatation of the expanders? Because this is one of the very important problems.
I think the pupil, there is a natural tendency in these patients to go for pupillary constriction. So because we have not addressed the basic process which is causing constriction, these pupils tend to come back normal. If not small, they tend to come back normal.
Right, very nice. Thank you very much. Thank you.
One question to Dr. Amit, please. What's your opinion about this phacorexis, which is coming recently been discussed? Of course, it's an old topic. But it is
phacorexis basically phacorexis is making a puncture into the anterior capsule, especially in mature intumescent cataracts with the help of a phaco probe. You insert your phaco probe, it should not be a Kelman tip. Actually, they recommend a 15-degree phaco tip, and with a very minimal power setting and a minimal vacuum, you just straightway go and punch it in the center of the anterior capsule and release it. So you'll have a capsular flap which is already created, and because of the suction which is there, the vacuum which is there in your phaco, it will aspirate all the liquefied cortex and you'll have a capsular tag, and that capsular tag then can be used to make a rexis. But I've tried in a couple of cases and we have our infinity, so we don't have the 15-degree phaco tip. When I spoke about it to others, it always gives an unpredictable result. I think in India, Dr. Mohan Rajan is the only person who is doing phacoexis and nobody else.
No, actually, this concept was very nice, like to do the phacoexis, but I tried in some of my cases. In one of the cases, tried to do it, and it captured everything and pulled out the capsule.
In
So
fact,
this is not a very simple or very safe technique, because phacoexis is a
safest technique would be, as I told you, the two-stage Rexis. That is the best thing to do, and use sodium hyaluronate. You have the Indian companies which is available for 400, 500 rupees. And another option what you can do, which I have been doing in some of the patients, is if you feel that the AC is too shallow and the interarticular pressure is too high, what you can do is just before the surgery, you can take the patient to your yak cap room, do an anterior yak capsulotomy, and immediately after that you can take the patient to the OR. You will have this liquefied cortex coming up into your view, but once you take into the OR and stay in the capsule with the anterior with the trypan blue, and then you can wash off all those loose liquefied cortex which is there, and then inject the visco and do the Rexis. Couple of cases I have done, and I got very good results with the anterior yak capsulotomy. The setting should be about 1.2 millijoules itself.
The access of YAG laser is not always there, so that is the main problem. And still simpler technique to tackle these cases is, the most important thing is when we use the 26 gauge needle to puncture the capsule, so that should not be done. So this is the most important thing, because the needle it's like a knife. When you put it into the capsule, it creates a horizontal cut on the capsule, and this horizontal cut, because of the pressure, extends to the periphery on both the sides. This is what happens. So if you at all don't have the YAG facility, or don't have the perfection in starting with a small Rexin and then going circular pattern and making it bigger, the best way to do is you use a needle shift punctum dilator. See that it has to be round. The tip should be round. It should be pointed tip, but the back of the tip should be round. The needle shift punctum dilator. The punctum dilator we use for the punctum dilatation, it is round and tip is sharp, and the back of the tip is round. So you can bend it from the front portion, a 2 millimeter bend, and you can use it like we use the 26 gauge needle to puncture. So you just puncture with that. You make a 1 or 2 or 3 puncture. So these puncture will never extend to the periphery, and you'll get an opening, and the fluid starts squeezing from the tense capsular bag. And then once you squeeze the whole fluid from the capsular bag, then you can start your capsular axis that you can use either the 26 gauge needle or the forceps, whatever you like to. So this is, I think, the best, because I've been using this technique for the last now many years whenever I get these kind of cases.
One thing as regards the concept of phacopuncture. So from where we have got this idea, and Mohan Rajan is a converted vitreoretinal guy converted to phaco. So now for vitrectomy, they are using ultrasonic energy. Earlier we were told that if you have a vitreous in the anterior chamber, don't use phaco, shift to vitrectomy. Now what they are doing vitrectomy using the ultrasonic power. This is a name, vitreolysis, or Vitreon, some new machine has come. Huh? So, yeah. So now what I am going to do in my next case is, if I need a vitrectomy, I will use my phaco probe to do the vitrectomy. So I think that idea starts from here. But then you need to have a lot of experience in training to do that phacopuncture. So phacopuncture is not a good idea to start with. And as has been mentioned by Dr. Prasad, if our transcapsular pressure variations are not much, then probably our extension will not occur. So if you can use only, whether you use methyl cellulose or you use high viscosity thing, it doesn't matter. Your puncture should not have a vertical pressure, and if your puncture is not having vertical pressure, and if you are able to get the initial release of intralenticule pressure, probably extension will not occur.
Okay. So now I think the time is over, and we conclude this session here. And I thank you, all of you, for nice hearing being here with us. And I thank you, my speakers, Dr. Amit, Dr. Malay, and Dr. Vinod Arora, and Dr. Harshul also. Thank you very much. Thank you.